Very good evening to all of you. At the outset, I would like to thank Ajanta Pharma for this wonderful summit and inviting me here. Thanks a lot, Dr. Lalit sir, for giving me this opportunity to present this topic. OCT in day-to-day practice. OCT is such a big topic that in 8 minutes, I don't think anybody can do justice to OCT. OCT is now, as Dr. Lalit sir was saying, is now a part and parcel of every clinic. I'm not talking about a retina specialist, but it's part and parcel of every sitting, every anterior segment surgeon's clinic also, because it is one of the most wonderful tools which has broken through the retinal diagnostics totally. One cannot imagine a practice in retina without it today. So I'll not go through the details about OCT. We know it's a non-invasive tool which gives us a very high resolution, almost akin to your histopathological kind of images in real time on patients. Gives us both qualitative and quantitative data to look at. And it has gone through its generation of development, growth, and we have moved over the years from some hazy images to some wonderful high resolution images in today's world. As the generations have grown, the resolution has increased, the scanning has become much faster. We now get three-dimensional images. We get large data maps so that we miss out, even layer by layer analysis is happening. We do not even miss out on smallest of lesions on retina. It had limitations in terms of the area that could be scanned. That limitation has been broken. We have gone deeper in OCT. We have gone wider in OCT. So OCT is really now mapping each and every layer of retina to a large extent to even periphery also. So this is what happens when one moves in generations. Smaller lesions which earlier machines could have missed, now with more number of scans, those small lesions are also picked up. You get beautiful 3C sets also. So as I was saying, OCT is not a tool only for a retina specialist. It is a tool for anterior segment surgeons also. In your practices today, your patients are more demanding. They want to know what is happening in their eye. They want you to predict how well they'll be seeing post surgeries. Today's are not very forgiving if you miss out on diagnosis. So keeping all those things in mind, OCT has become a kind of an indispensable tool. So I'll go through my talk through few examples and photographs to show how OCT can help you in your practice, and then what OCT interpretation all goes through. So just to begin off with a 75-year-old female who had difficulty of vision of 660 with some cortical cataract, fundus were quite tessellated. She wants an opinion for cataract surgery. Will she be able to do? So in a practice where there is no OCT, sometimes you just go ahead with the cataract surgery and then later on get surprised by what is there in the fundus. But if you see something like this on an OCT scan, you can prognosticate. So this is a typical scan showing a loss of tissue here. There is thinning at the fovea, a lamellar macular hole developing. These are very subtle changes which may be missed on clinical examination, which OCT, because of its high resolution, you are able to pick them. Not just this, small macular holes which appear as defect in retinal tissues, extra membranes going on the retina as epiretinal membranes are very easily picked up on your OCT scans. Not just it picks it up, it also helps you to counsel patient when you're looking at pre and post images. You're able to show, okay, this was the kind of image which was there before surgery. Now today I've done surgery. You're able to show them that you have done your work. You have shown that the hole has closed. So it gives you a very beautiful pre and post analysis also. So an epiretinal membrane, you have done a surgery, the retina is looking flatter. So these are the things you can use to counsel your patients. Take another example of a 65-year-old diabetic who has been on treatment, laser, anti-VEGFs, with has dense nuclear cataract. He wants opinion for cataract surgery. So you are not sure what path to take, whether diabetes needs treatment, macular edema needs treatment. You can't take a decision today without an OCT in your hand. You look at the OCT in terms of your fundus examination will show you hard exudates, your hemorrhages. You know there is diabetic retinopathy, but your OCT will show what kind of thickening it is. You have subretinal fluid which appears as the small bump under the fovea, or intraretinal fluid as hyporeflective spaces within the retina. So all these changes you pick up on in diabetic eyes. You classify them as focal, diffuse, fractional, subretinal fluid, which decide what kind of a treatment plan you're going to make for that patient. So you can have subtle edemas which are focal. You may consider focal edema, some amount of laser. You may have large amount of thickening with lot of hard exudates shown as hyperreflective foci or hyperreflective dots in this retina. You may have tractional edemas which appear as these membranes which are pulling on the surface of the retina. So all these kind of decision making can happen once you have OCT in your hand. Large amount of subretinal fluid. Dr. Rishi is going to be talking about these biomarkers also in his talk, which can guide what kind of a treatment pharmaceutical agent will you be using in terms of treating these eyes. So based on OCT, the classification of diabetic edema has also changed, where you now classify it as center involving when it is within 750 microns of the center of the fovea, or non-center involving edemas. So all these kind of decisions are possible only based on your OCT. Again, you see pre and post analysis, not just in terms of qualitative scans, you can also compare them in terms of quantitative. You get these maps which show the thickness. You can compare pre and post and see how the eye is progressing in terms of area of edema, thickness overall of the retina. Another example, a patient who has been on pilocarpine, 80-year-old, loss of vision is there. You don't have a very good view of fundus. OCT works beautifully even in small pupils. So you can do an OCT and you see this kind of an OCT picture with RP elevations here, subretinal fluid seen as this gap here. You know this patient has a neovascular process happening in the eye. You need to consider this patient more on another line of treatment, not for cataract surgery immediately. So AMD, you can pick up drusense as these elevations under the retina. You see PEDs, pigment epithelial detachment, where the retinal pigment is lifted up. This is a pigment epithelial detachment which could be serous, or a fibrovascular where you see this hyperreflective material under the PED. Large hemorrhagic PED appear as dense hyporeflectivity with total backshadowing seen in AMD patient. So these are a classic or a classic CNVM which appears as this hyperreflective band in the subretinal space, which is called as type 2 CNVM. Or earlier known as classic CNVM, which you are seeing here. You even make out changes post-injection, where a post-injection large PED is ripped and you see the curling of the RP happening as an RP rip patient here. A disciform scar and end-stage disease, wherein you see a thickened hyperreflective band at the RP choriocapillary complex and foveal thinning. So all these kind of changes in an AMD patient you are able to pick up and counsel your patient. Again, a pre-post analysis, whether qualitative as in the previous slide or a quantitative, can be done and shown to your patient. You even look at a patient in post-operative conditions also. A patient who has post-cataract surgery come to you with drop of vision 2 weeks after surgery, and you see this on OCT. You don't have to think too much now. You're dealing with a post-operative cystoid macular edema. You know what kind of a plan you need to do, and you can counsel him and manage him accordingly. So these are some examples. I'll run through a few other slides to show all different conditions in which OCT can be useful. A central serous chorioretinopathy, where a subretinal fluid pocket can be seen with a good neurosensory retina over it. Vein occlusions, CRVO, BRVO, hemi-CRVO. You see different pattern on OCT. This is one of our publications where we describe different pattern of on OCT in these vein occlusion cases. A CRVO which shows more diffuse kind of an edema, a BRVO which shows more differential edema, wherein the retina vein which is blocked is showing edema and the other half is showing a normal retina. An arterial occlusion which shows as a thickened neurosensory inner layers of the retina in an arterial occlusion. A parafoveal telangiectasia, disease which is very often missed on clinical examination. You do an OCT, you see loss of loss of tissue at the fovea. You see a outer retinal cyst, an ILM drape sign, which is just a thin ILM on the top. You know these eyes will not have vision post surgery, cataract surgery of 6/6. You can counsel these eyes accordingly. So beyond this, the OCT spectrum has expanded. We have gone, as I was saying, we have gone deeper and wider, and add to it an OCT angiography, which further increases your understanding of the disease. So enhanced depth imaging on OCT, wherein now you can image the choroid, the layers of choroid in a much better way. It's very useful when you're dealing in conditions such as VKH or CSER, where you can actually measure choroidal thickness. You can see what is happening in choroid in such eyes. There are a lot of quantitative analysis on choroid which has started to happen. You measure choroid, you do choroidal vessel density analysis, which you can do on these OCT images. The scan lengths have gone wider. It is no longer limited only just to the macula. You have large scan lines from 12 mm to 16 mm where you can, and then the montages of these scans can be done to give a real wide view of the retina. OCT angiography, which gives beautiful array of vessels which you can see in the superficial layer of the retina, the deep layers of the retina, and the choriocapillaries in the outer retina. So any whether you have a good vascularity involving the fovea, loss of vascularity, as in this patient of BRAO, where you can see this whitening happening and you see a total loss of capillary network in both superficial and deep plexus area in the superior in the retina there in the upper half of the retina. So such kind of beautiful images you can pick up on OCT. You can diagnose different condition on OCT angio. It has become so much close to what you used to get in FFA images. You can see this neovascular complex in a wide field OCT angio image very beautifully with non-perfusion area in a patient of both eyes PDR. So such kind of images are possible, but the future doesn't stop here. The future that we are looking at in OCT now is not just at looking at these images, we are looking at even flow in these images, whether they are going to be high flow vessels, low flow vessels, which will help us in further understanding the disease and planning the treatment. This is something which we are really interesting and looking forward to, which is called as Vista scans on OCT. We are really looking forward to this. So to sum it all up, OCT has revolutionized the way we look at a disease. It is an indispensable tool for any kind of ophthalmic practice, whether it's the anterior segment, VR setup. Definitely it cannot work today without an OCT, and the scope is expanding much further, but the eyes will see only what a mind knows. So it's very important to understand this machine, spend time with it, and see more and more images to understand this diagnostic tool much better. Thank you.
Thank you, Ritesh, for this wonderful talk on OCT. Let me start with one question. How many present in the audience? I see more than 100 people, big names, big surgeons. How many of the cataract surgeons do OCT as a routine prior to cataract surgery? Show of hand, one only. All of you. The thing is, we, at least retina people, do recommend all the cataract surgeons to be doing OCT free of cost, at least for all the patients. The reason I said free of cost is, because money becomes an important issue. It's not only because Ritesh started his talk with two beautiful examples. One is a lady undergoing cataract surgery, and second was a gentleman of diabetic undergoing. Because all these visual surprises will not happen. There have been two studies I am aware from India only where surprises have happened despite being labeled normal by even a VR surgeon. So therefore relevance is there, at least for counseling, because he uttered this word counseling at least 15 times. Counseling, because patient expectancy today is very high. Titial does an excellent cataract surgery, no endothelial loss, even gain may be happening in endothelium, but very important, the next day if the patient has metamorphopsia or something, patient does not understand all these things. So if you have guarded the patient beforehand that there is a lamellar macular hole or a ERM, his vision may be compromised. So my request with folded hands to all of you is, if you have an OCT, even if you don't have, please get an OCT done. I'm telling you, because pictures are so good. You see, if you tell picture to a patient, this is normal, आपका ऐसा है, ये है, so he will be very satisfied that मेरा OCT normal नहीं है, इतना normal नहीं है, OCT की requirement है. So one question I'm going to ask to the panelists, otherwise we'll move on. And second talk is again by another imaging expert whom I envy so much, because this gentleman from Nagpur does such fantastic work on VR surgery. So we called him all the way from Nagpur on wide angle imaging. Prasad, you can come. Ritesh, we will not ask you any question, but
thank you
because of paucity of time. And one question I had maybe for Ajay. In a diabetic plus cataract patient, give a very brief two-line answer for the benefit of you.
Sir, I think when we got the OCT in 2007, the first indication which I think a general ophthalmologist for a diabetic patient should know, what are you looking for from an OCT? whether the diabetic macular edema is tractional or non-tractional. If it is tractional, it's a surgical treatment. If it is non-tractional, it's a medical treatment. Once you have defined that, and that OCT is able to define very well, then we go subsequently and look at greater details into what the OCT is telling us, how the macular edema is behaving, and that's what I would be looking at.
So my actually question was from the anterior segment surgeon point of view. If you are operating Titial in a diabetic patient, OCT is a must. Is a must to because I wanted your attention because you're talking. In a diabetic patient, believe me, fundus may look normal. Fundus may look normal. We have featureless retina in diabetic patients. There may be diabetic macular edema without the presence of exudates. There may be DME without the presence of hemorrhages. So it is important. Please have an OCT prior to cataract surgery. You will be rewarded. 15 to 20% of all cataract patients who may be labeled as normal on 78D or 90D or indirect will have some findings on OCT. So that is the alarming figure. So with this, we will move on to the man from Sakshi Netralaya, Nagpur, because he has a lot of interest in Ingenuity machine, wide-angle imaging, everything wide he does.
Thank you.
Because this is important, because you see, imagine when we were in our center, you see 30 degree or 40 degree compared to now 200 degree. 200 degree, because wide-angle imaging system, no retina surgeon today can do without this. So Prashant,
yes,
the floor
sir.
is all yours.